A very warm welcome to all the participants.
Oh, sorry.
Yeah. Should I begin, sir?
Yeah, please do.
Okay. A very warm welcome to all the participants joining us from across India and beyond. Hi, Sanchita Biswas, Deputy Manager, KCS Fair India. I'm delighted to welcome you today to the today's thematic webinar on mental health crisis, strengthening psychosocial support in emergency, organized by Spare India Academy. As we all know that India is a highly vulnerable to all varied kinds of hazards that trigger disasters like cyclone, floods, earthquakes, pandemic, displacement, and conflict. These events not only trigger and cause physical destruction, but also leave deep psychological scars. Disasters disrupt social cohesion, erode coping capacities, and have long-term impact on mental health. Survivors often experience stress, grief, anxiety, depression, which, if unaddressed, may escalate to severe conditions such as post traumatic stress disorder. Therefore, this webinar will focus on amplifying the importance of integrating psychosocial care into emergency preparedness and response, drawing from national and global experience. It is my pleasure to introduce our moderator for the day, Mr. V.R. Raman, National Convener, Public Health Resource Network. Mr. V.R. Raman is a senior development and policy expert with nearly 3 decades of experience across health, WASH, nutrition, education, and climate resilience. Currently leading this Currently leading as a national convener public health resource network, he also serves as in-country focal person for sanitation learning hub and also a system thinker with deep grassroots and policy level expertise. He has guided key national programs and institutions including Water Aid India, My Tenant Program, SHRC Chhattisgarh. His work reflects a lifelong commitment to equity, public health, and people-centered policy change. With this, I hand over to V.R. Raman sir to leading us through today's discussion and introduce our esteemed speakers. Thank you. Over to you.
Thank you, everyone, and thanks for the introduction. So it is for me, it's a reunion with Mr. Rajendra during my water aid period and previously when I was studying the Tamil health systems, when he was the director of the Tamil Nadu State Drug Supply Corporation. So that was the time that we used to interact a lot, and also through some common friends like Vilash and others who used to interact. So it is quite. I'm quite glad to welcome you, Mr. Ratna, and for dealing with this topic. You are the right person for the reason that during some of the emergencies, right from the tsunamis and the recent floods, Tamil Nadu government has identified the importance of the mental health interventions, and a lot of volunteers and the government officials together was trying to uh, put together some kind of initiative to make people calm and settle and to make them resilient towards the realities and to move forward. So that part is very, very important, and I'm sure, although he has taken a voluntary retirement, which I realized only day before yesterday, but his tenure, both in the government of India, also in the Tamil Nadu, I have seen that whether it is part of the urban development, whether it is part of the health, whether it is part of the other departments, all these has been something that very people centered, very much people centered, and trying to do, uh, trying to fill the gaps wherever such gaps are identified. And he was quite open during his official time to hear from people about what are the gaps, then to uh, address them, ask them to suggest solutions and address them. So that kind of a administrator to open this discussion is a very useful.
Prasanjit ji, can you please switch off your mic, Prasanjit Khatua ji?
Thanks. Yeah. So I'm very glad that to open this discussion we have a person like. So without taking much time, the overall program we have put into four specific schemes, and then we will go one by one, and I'll introduce the speakers that way. And Mr. Ratno, I hope you will be here till the end of the workshop, or I should put the question answer for you immediately after your session. I don't know what is your
No,
schedule.
I'll maybe in between slightly, but
You're mute now. You are mute. You're still mute. Uh, I think Sanchita, you'll have to unmute.
Yes, sir, that's what I'm trying to do. Uh,
yeah.
Yes, now you are.
yeah. Hmm.
So Sanchita is controlling my voice. Earlier it was the government that was controlling. Now today's session is Sanchita who is controlling. Mm. So yeah, I'll be now I have much more time, and I'm on this side of the fence now.
Right,
So I'll
right,
be
right.
happy to be part of the discussions, and I can be
Definitely.
more freer and franker.
Then it will be very useful
Yeah.
so that we can have that joint discussion with other panelists. So I would request you to start off with the keynote and the topic that is suggested for you is to provide a broad overview of how psychological and mental health aspects are taken care and to be taken care during the emergency situations. Over to you, Mr.
Uh, Thank you, Mr. Raman, uh, and thank you, Sanchita, and thanks to Spare India for inviting me to this event. Uh, Other important key speakers today, uh, Dr. Prakriti Kashyap, Dolphil Ramanji, and others, and all the esteemed people who are participating in today's event. I'm happy to join back this side of the fence. The citizens, of course, as a government, also, I was always there to represent the voices of the citizens, but now I've taken voluntary retirement and I'm happy to join this event as my first engagement in the area of disaster management after I have taken VRS. So, thank you, Sanchita, for and thank you uh, to Vikrant for this opportunity to be part of this series of discussions. Uh, well, uh, I've been given 10 minutes, so I'll just stick to more of a broad framework. And during the discussions, I'll bring in more of the practical wisdom and the experiences during the discussions. Uh, we see that continuously it's needless to emphasize that in the recent years how the intensity and frequency of the disasters is increasing not only in the Indian subcontinent but across the globe, and it's we are seeing it more harsher version of this reality in our Indian subcontinent. We can see the Himalayan region totally under turmoil. We are seeing how the floods, flash floods, landslides, and other climate induced disasters are affecting our people and communities. uh, when we do the assessment of the losses and damages, often our focus is on the tangible assets because they are visible. The destruction trail of destruction goes much beyond the visible infrastructure and the economic losses that are there, though the economic losses are also perpetuate the further aggravate the other psychosocial distress. But the intangible assets of the community in terms of loss to the psychosocial aspects, even uh, there are losses to, for example, somebody is a great poet or a learned man of particular language or literary tradition, which is at verge of extinction. And if we lose this kind of person, we are not only losing a human being or a this thing, but we are also losing a cultural tradition, which is also a very important intangible asset. So mental health, mental well-being, the psychosocial well-being, the social support system, these are also very very important assets of a community, which are not that way visible to people, that how much of deep impact they are getting. I'm glad that I studied psychology as a master's student in psychology, and as a practitioner of disaster management at the field level. I always excuse me, there is a like the disasters come unannounced, my dog also has started just barking that way. So bear with me the background sound. So uh, that way the psychosocial, emotional and social well-being need to be integrated into the disaster management. And when we talk about the psychosocial care, so the caregivers, and this need not be seen as a simply a clinical kind of approach, that there are people with some as if some problem. The psychosocial care has to be seen uh, as a not only immediate but also a long term long term intervention, or the how the long term impact is there on the individuals, families and the communities. And this is also, as I was just hinting, that uh, so these are not two purely categorically separate sides, that is a human losses, the psychosocial impact and the economic losses. We have seen during COVID that how psychosocial impact as a, it's a independently that disaster is bringing at the same time, when people lose their jobs, when they lose their houses, they lose their entire life's earning. Then post that their breadwinner passes away, the children become totally destitute and either semi orphaned or orphaned. They lose their schools many times. And we have seen during COVID this was rampant across the country. Large number of children were out of school. So sometimes peer group also gives us sort of a psychosocial support and care. The community is the best counselor, but when the community support itself is at stake, then it is something is worrisome. Sanchita, I'll be very shortly summing up my comments. I can see you getting little anxious, so I'll not
No, 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 sir.
make
Please
any
take your
impact.
time.
Okay. Uh, I'll just like to mention two, three just points quickly. One is that in 2023, Government of India has brought out national guidelines on psychosocial support and care, which is a good step, because having a framework, and this makes it actually part of response, recovery, reconstruction, rehabilitation, and the entire cycle of disaster risk reduction and risk management. So which is a good thing that we have a mandate from the government and authorities to address this issue. But nevertheless, uh, the gaps exist in the government is that the left hand does not know what the right hand is doing. This might have been brought out by one vertical, but the health department mainstream still may not be sure about that. We have a huge gap of manpower availability. Forget about the health sub center and PHC, even at the district hospitals and taluk hospitals, we do not have an institutional framework of mental health care still percolating down. So taking that to the community level, because if you do not have the large number of people trained into psychosocial support, at least at the PSC level, then it will be very unrealistic to dream for us that we can quickly after disaster create a training of the people, multi-layered training, and we can keep the counselors ready. So we'll have to definitely use the community participation. We'll have to use identified people from community who may not be professionally qualified, but we may have to through these kind of events, and we have to identify the resource persons at each of the state, and maybe gradually we have to keep some people at the community level also trained. But institutional uh, availability at the sub district level is a very very critical factor. So while guidelines is a welcome step, but I think resolve of the states and the union to provide the necessary manpower so that this gap can be bridged in not only making the mental health and the psychosocial care as available, but also affordable and accessible to the large number of people at the normal times, as well as during the distress generated by disasters, both man-made as well as the disasters that are induced by natural factors. And uh, the the way forward is that we need to break silos between government, NGOs, health department, and various agencies of government, and along with community, they have to work as a whole team. Second thing, that psychosocial support need not stand as a separate issue of discussion and theme of discussion. We need to integrate that. We need to mainstream that into disaster risk reduction strategies. It has to become part and parcel of disaster management. We need to have our roadmap for training large number of volunteers at grassroots level and middle level, and for that it is not possible for government alone to do that. The non-governmental organization, the federations of community social self-help groups and other community-based organization also have to join hands. Also, public private partnership can be explored, uh, and we need to see that how both the vertical and horizontal integration is possible to create a holistic framework for addressing the needs of community, and particularly the most vulnerable, for the children, the women, the elderly, the survivors. And not limited to this, many a time we have seen during recently Silkyara tunnel rescue operation, as well as the train accident in Odisha, that how the people who were at the forefront of the rescue operation, when they deal with the dead bodies, what kind of impact they suffer. And I'm a first an example of myself, that as a first responder to tsunami, when my first 2 days I could not sleep, and I had to handle large number of dead bodies, the injured, the huge load of communication. I'm otherwise quite composed a person, uh, uh, except a occasional disturbance. But I found myself that my behavior is changing after 4 or 5 days, that I was not able to cope up with the kind of stress I was living through. And and that was visible in the smaller issue. My threshold of tolerance was going down. And so these are all impacts. Even the trauma givers, those who are there at the forefront, the first line people, those who are into management directly at the grassroots level, they all suffer these immediate effect. But the immediate as well as long term impact is suffered by those who are directly getting affected. They're getting devastated, their loved ones get they lose their lives, and those many of them survivors, they themselves get severely injured. And so we'll have more time to discuss about do's and don'ts, and I'll be drawing from my lot of experiences of managing large number of disasters, including tsunami, around 5 cyclones, 5 to 7 flood situations, as well as COVID. I was one of the 27 officers in the country who managed the field level work. So I'll be happy to engage with you during the discussion session. Thank you for the opportunity. Wishing for a very, very meaningful and productive discussion today. Thank you.
Thank you, Mr. Ratno. Very insightful initiation of this important discussion. You have highlighted some critical areas like the need of large scale capacity building, and the lack of coordination amongst not only within the government department, also with civil society and other actors. And you have also brought in the important issues of the institutional bottlenecks that this kind of a large issue is facing. And finally, the need of various kinds of strengthening of the current arrangements for psychosocial care and also psychosocial management during the disasters and emergencies. And you have brought in examples of COVID, examples of tsunami, and so on and so forth. All very important. I am just putting some questions, not to respond immediately. You can take some time to think about them. One is about, you have said this large scale capacity building uh, it's a challenge. So one thing that I missed during my introducing you is that you are also the director of the National Institute of Disaster Management, the apex institution for capacity building on disaster related issues in the country. So in that sense, you have seen, how the transmission loss happens during the capacity building process, right from when you travel from national to the local where the actual kind of intervention is required. So, in order to address this challenge of capacity building, uh, or what are the key challenges and how can we address them? That kind of a question. Second is, around we have a mental health policy at the national level. How oriented that policy is towards emergencies and disaster-like situation, wherein the phenomenon of emergencies and disasters in the country is now it has become rampant. It has become recurring. So this integration of the policy and policy implementation framework needs to be more oriented towards these situations. How we can do that? These are the two critical questions that I'll place. Another question I have is I'm just placing it. That is common for everyone. Disaster is also a major intersectionality that we face a lot of intersectionality because disaster itself is a problem. If they are disabled people, if they are old age, if they are kids, the kind of the impact of the disaster adds up, and the mental health challenges also are different. So how capable we are to handle this intersectionality challenges related to mental health? These are the key things that I'm keeping as a reserve question for you. We will come back to you. Thanks for this critical opening remarks. Now I am moving to Dr. Prakriti Kashyap. She is part of Doctor for You. Doctor for You is another organization which has, when I started to see Doctor for People, it was a very small initiative. Somewhere in Bihar they started, and during the disaster situation, the kind of contributions Doctor for You have made, and then grown as a national level organization, which is anchoring lot many critical importance. Uh, Critical important initiatives has been remarkable. And Prakriti and I, we have been into several panels so far. So it is so she is a dedicated and energetic medical professional. She worked on healthcare management, also including disaster response. She is the director, health centers and clinical health, and also the medical superintendent at the Meena Devi Jindal Polyclinic, Delhi. And she works with the as a volunteer. She is extending her support to Doctor for You for a long time. So Prakriti, over to you, wherein we would expect you to broadly provide the stress, trauma and the survivor responses, how they shape in emergencies, how psychological and emotional impacts of disasters affect the population, and how the survivors respond and how the operations happen during those critical times, and the caregiving approaches. What kind of approaches should we prioritize? Over to you.
Thank you so much for the warm welcome. I'll just do my screen share. I have prepared a small presentation to just help us go through it, and I hope that it won't be boring. I'll not take a lot of time, and
Sure. Yeah.
I hope that I'll be able to explain it all in the minimum time that I can take. So, can you see my screen?
Yeah.
Okay,
Please
great.
make it full screen if possible.
Yes. Yeah.
Yeah.
So,
Just
now what we are trying to do here is to understand the stress, trauma, and the response that we do in emergencies. So, before I actually begin the presentation, I would like to highlight the fact that a lot of emergency response is not just taken care of by the, I would say, the emergency responders, but a lot of people who would be part of the community who are generally not involved in such activities, but because they are I would say more strong mentally, or they have a stronger willpower in general, and they try to respond it and help the people as much as possible. So right now, you know that a lot of flood situation is going on in Punjab, then it was there in Himachal, Uttarakhand, even UP, and many other places. So the kind of, I would say, trauma that is happening physically, you cannot even begin to imagine. But the mental trauma that is also associated with it is also very high. I mean, like, imagine that you have to leave your safe place, because your house is where you feel safe, and you have to leave that because it's inhabitable right now. So I mean, like, we can discuss all about it, but whoever is suffering can only understand, or light, how that is. So now, going forward, like, we know that the disasters are mostly emergencies. They could be natural, they could be man-made, like fires and all of that. And as I said, physical and mental impact both is there. And even if we talk about physical trauma, but I think the mental trauma is much more than we can imagine. And it just not, I mean, like, it's there during the disaster, but it is there sometimes even post disaster for many many years. And that psychosocial impact that it creates, I mean, it disturbs a lot of things which we will discuss subsequently. So, beginning with the psychological and impacts of the disasters that we can look at. So, there are certain immediate effects that we see. Some are short term, which would, I would say, last for 2 to 3 weeks, and long term would be which is once you have been again put back in the situation, like in your house, and you have rehabilitated, and that impact is there even post that. And I would say that there would be a vulnerable section of the society, like young kids, or older people, or people who are physically disabled, or like there could be mental disability also. So such kind of people are, I mean, like, they comprehend these situations in a very very different way, like any other individual would be. So if you're talking about an immediate reaction, so not being able to act, or having being yourself in a panic mode is one of the shortest thing. Like, even if you, let's say, fall down on the staircase while walking or somewhere, I mean, like, that immediate shock or that panic is there with everybody. But now, let's say, you were in your house and suddenly the water came, and like, you just don't know what to do. So that is what fear and shock and panic gives you. I would say the immediate grief would not be there for the first few hours, because I mean, most of the people are not able to comprehend what is going on and how to react. Um, um, and it also depends, like, there are certain people who face such kind of situations every yearly, and then there would be some people who have faced this for the first time. So I would, the impact is also a little different for each of these people. So that is there. If we begin to the short term ones, so then you get anxiety, you get sleep disturbances, there is guilt, that is anger, like, all stages of grief that you know about, that can be there. And when you're talking about long term risk, so you get post traumatic stress disorder, you could be in depression, they could be suicidal ideation, substance abuse, any sorts of these things can happen. And there are different reasons, why these things are happening. We'll discuss about that. So normally, when you are in a stress situation, your immediate response is built upon the adrenaline that is there, like your cortisol that is there, so it will get released, and that will give you rapid heartbeat and everything. That is the time you will act fast, and probably the emotions of grief and other things won't really come in. Now the problem actually begins once these hormonal levels starts decreasing, and like you begin to understand the reality. Okay, now I don't have a house, or now how will I feed myself, all of those reality things that can set in, that is when the real problems begin. Now there's another problem that there are a lot of people who are dependent on daily wages, or who are somewhere, I mean, like they, like who does not have a backup system in any place, who are getting affected. Now I would say, like if we are talking about responders, as I said, the responders could be from the community, and the responders could be from any other place. So both of these people are getting impacted. The community ones are going to feel it a little differently from the responders one, and we'll try to cover it in both the ways. So now like there are two things that happens. First is, like you are looking at a lot of negativity around you. There are dead bodies, let's say, floating around, or there is somebody who is close to you, you have lost. You don't know how you can go back, or how your future is going to be. So there are a lot of different kind of things. Now once you have been rehabilitated back, or I would say, I mean, I think it would be easy to understand when I'll give more examples eventually. So let's say you were there in a, let for a situation, and you were delivering food packets, or you were delivering sanitary napkins, or you were trying to evacuate people from those areas. So as long as you are able to help out, or you are able to kind of create a positive situation, positive in a way that whatever effort that you took at that time, it somehow resulted in some kind of positive output, it's still okay. But once you are back, and then you begin to look at I would say, the flashbacks that you have for that incident, I think that actually leads to a lot of PTSD that is there. And I would say PTSD in the victims and PTSD in, let's say, responders is very, very different. Like a lot of people, I would say, who have been responders, and who have been, I would say, suppressing all the feelings or emotions that they had, which could be, it could be sadness, it could be anger, you could have, numbness also. I mean, it depends. So that actually leads to a different kind of a behavior that you can see it, in a when there is a significant amount of time when you have gone through anxiety or depression or any other feeling that you've had. It could lead to memory problems, it could lead to difficult concentration or confusion, or it would be like, you have suddenly become an introvert when you were not. And like you just can't I mean, like your behavior changes in a very, very different manner. Like somebody who is an outsider, who has been living with you, would be able to make out that something is wrong with this person, which a random person may not be able to make out, because he just didn't know you like you were before. So now, I mean, highlighting these parts, I before I went to the coping mechanisms and everything, I would give you one or two examples. Like COVID is, I think, something that I have seen very, very closely. Like I have worked in earthquakes, I have worked in floods, but COVID is, I think, something very different. Like all of us can relate to that. How there was a time then that when the healthcare workers were not allowed to enter their own societies or their own house resident premises, because the society was fearing that they're going to spread the infection over there. So imagine you are trying to help somebody out, and you cannot live in your own comfort. So that is a huge problem. I mean, like imagine the mental turmoil that person would be facing. And we saw that. So, and that was one. Second thing was that all of us are stuck in one place. So you are in a COVID center, or you are in a, I would say, you are in a lockdown situation, so you are just stuck at one place. You are not able to do what probably you like doing, and you can't do it right now. I mean, it's just not there. So now that also creates a lot of problems. So I mean, we used to see incidences where these COVID patients would try to commit suicide. And not just that, even the staff would also say ki, why are we stuck like this, why is this happening, when will this get over, because it just felt like never ending. So what we came up with was creating group activities, so that each of them could share, because that actually helps a lot. And we tried to do some kind of video call mechanism where people could talk to their families and provide them proper spaces. But that worked in COVID, because I would say the problem here was the spread of the infection, but I think your surroundings were still better. Imagine now you're in a flood like situation on an earthquake, where your house is completely destroyed, or you can't go back, or once you have reached back, you just see everything that you have built has completely gone. So now that stress of redoing everything that you have done is a task. I mean, so again, there are a lot of counseling sessions, I would say, psychosocial support that is required. Practices like yoga, meditation helps. But again, this is very easy to say all of these things, but what happens is, like, there's a person whose house is not there, his all crops and everything that is gone, because he was part of the community, and now he has to go back, and he doesn't know where to start from. So I mean, like, wherever you begin from, it becomes a problem. And when you're talking about the responder part, so let's say I was there when I went. I mean, I was very, very recently in Mandi, when the cloudburst happened. And I mean, like, I was there in the hotel because my flood response was going on like 10 days before that. So I was just there. And suddenly the light was not there. So now my first thing was, okay, now I can't do any emails now, because my laptops won't work, my phones won't work, so I can't communicate. Now second problem is, my family is away from me. So now, because my family is away from me and they are hearing it on the news that there is some cloudburst in Mandi, now they would want to know, how am I feeling, am I okay, am I not. So the first thing is that I have to console them that, okay, I'm fine, everything is okay over here, we are just assessing the situation, and we'll just move accordingly. I mean, the first thing that a responder could do is be save themselves and then try to save somebody else. So, I mean, currently the situation in Mandi and outside is even worse than it was before when I went there. So that is there, and obviously teamwork is very, very
Maybe,
helpful.
Prakriti, we need to.
Yeah, wrap it up. Oh, there's just one more slide. Yeah, so that is, I was saying, so the I would say teamwork, networking, that is there. One more thing that I would want to mention over here is that alcohol and other thing is also something that people do adapt very fast. So we have to ensure that if anybody who is kind of susceptible, we could have questionnaires, we could talk to them. I mean, that helps a lot. So that is there. I think rest of the points I've already covered in different points. You can see how the trauma informed care is important. Like, before you have to anticipate, like, these people who are going to respond, they should be counseled before they have actually been part of the program. So that is very, very important. And I would say, obviously, after the response have taken place, I mean, they should again be brought in, and again we should have a discussion that is very, very helpful. So I think there would be more sessions on how role of caregivers and responders would be. So I am not going to cover that. But again, going to highlight that you have to look at yourself first. Once you can, I think then only you will be able to help others. So these are some pictures from those times. Thank you so much.
Thank you. Thank you, Prakriti. So I'm just, flagging some questions for you for further discussion, which we can do later, but you can take time for thinking. One is, civil society capacity in order to, I, while you were talking, I was thinking about Vikram Patel's book where there is no psychiatrist. Uh, so at least, using that kind of a manual or something, how can we make a large number of civil society volunteers who understand the problems? So, for example, in the last years, why not this thing happened? The Asha, the Asha of that area she was, despite lost her own family, she was into relief work. That kind of a situation comes, so it adds to the kind of mental challenges of that person. So how equipped they should be, how can we make them equipped, and how challenging it is at this point, and how can we do it in a large scale with Doctor For You and similar kind of organizations. I would like to keep that question for you. Now I am moving to Ms. Jyoti Ravichandran. Your name is correct, no? Yeah, okay. Because here in the note that I've given, it is written slightly differently, so I thought I'll check. Uh, so uh, Jyoti has, traveled from Ashoka University to various organizations to reach UNICEF uh, as its mental health specialist, and over last couple of years, you are with UNICEF, I understand, right? Yeah. So UNICEF is an organization, even for Sphere India, one of the key partners, and also UNICEF with the mandate of mother, women and children largely. Uh, the overall field level realities related to disasters and other social development and nutrition health, all aspects UNICEF look after. And the mental health vertical in UNICEF is relatively new. And as the lead of that, or as the key person over there, how do you see the overall mental health initiatives that are required for this, disaster and emergency issues? And your specific topic is around psychosocial caregiving for the vulnerable groups, such as the children, elderly, persons with disabilities, marginalized communities, etc., which is the intersection that I was talking about when Mr. Ratnu was speaking. So please throw light on this topic, and I'll also have some similar questions for you as well. Over to you, Mr. Ratnu. Can you put it full screen?
Hi, thank you very much, Mr. Raman. It's wonderful to be a part of this. I also want to really thank the speakers that went before Mr. Rajendra and Dr. Prakriti. Really wonderful presentations, and it's so good to see us talk about trauma in the context of emergencies in such good detail. As Mr. Raman said, I've been tasked with focusing on psychosocial caregiving for vulnerable groups. And I will just very quickly take you through my slides, keeping in mind, I think I have 15 minutes, so until 4 o'clock, and hopefully we'll have some time to discuss some more. All right. All right, so I just want to start off with some very quick key facts, right, which Dr. Prakriti also alluded to just now. The first important thing is almost all people affected by emergencies, they experience psychological distress, and it improves over time. Yeah. 1 in 5 people, which is around 22% of any population that goes through a disaster experience, who have experienced war or conflict in the previous 10 years, they've had depression, anxiety, post-traumatic stress, bipolar, or even schizophrenia, which we call a psychotic disorder, where there is a break in contact with reality. So these are called severe mental illnesses. And we know that normally speaking, the population, around 14% of any population, has some sort of a common mental disorder, which could be depression or anxiety. And that's really well spread. Emergencies significantly disrupt all services, but specifically mental health services, especially in low and middle income countries where there may not be mental health systems set up ready to go when there is an emergency, right? People with severe mental health conditions are especially vulnerable during emergencies because there might be disruptions to the medication they are able to access, etc. And their access to participate in basic planning will also be, restricted. I've just put in the box that we have a few frameworks which are very helpful to take the discussion forward when it comes to mental health and psychosocial support in emergency settings. The first is the National Mental Health Policy, and as very rightly noted, it does not speak too much to how do we organize ourselves at a time of climate disaster or a humanitarian emergency, which must be a very important part of that. And we have, of course, the national guidelines on mental health and psychosocial support in emergency of the NDMA. Very interestingly, in 2025, UNICEF had the privilege of organizing a national conference on disaster mental health and psychosocial support with the leadership of the National Disaster Management Authority and the Ministry of Health and Family Welfare. There, over 2 days, we had really extensive discussions about many of the issues that have started to come up already, which is in terms of preparedness, right? Like, how are we prepared? Are our systems ready to respond at a time of emergency within the critical period of a few hours after an emergency? And we also spoke a lot about the different frontline workers or cadres that are already present in ministries and their training on mental health, but also specifically in the context of humanitarian response. And the methods or the mechanisms through which we can quickly deploy a large workforce at a time of emergency, and that can only happen when all ministries kind of put their workforces together and we have a training or institutionalize thinking about MHPSS in emergencies across sectors. So who are vulnerable, right? So there is a very basic definition, and you will keep finding that you will add to the list of people who you think are vulnerable according to the context in which you are responding to an emergency. But largely, they are those who have a reduced capacity than the general population due to either genetic, physical, and psychosocial determinants, right? These could be age, physical, psychological, emotional, cognitive predispositions. They could signal socio-cultural, linguistic, religious, geographic, or socio-economic conditions that in which they live. And these determinants, they create barriers while receiving or processing any sort of information or any sort of service, right? And the example could be women, children, older adults, sexual minorities, persons with disabilities, and tribal populations, and pre-existing conditions. I've put biopsychosocial here, but really it could be socio-cultural. It's all of them. Pre-existing vulnerabilities make these group vulnerable even before the impact of a disaster occurs. The disaster simply amplifies their vulnerability or the intensity of vulnerability, which means our response has to be equally intense at a time of disasters. The most important thing here really is that pre-existing vulnerability does not mean that these individuals don't have strengths. And care should really be taken to validate and enhance their existing strengths despite difficulties, because as we said also in the previous slide, it improves over time. And oftentimes community people are really able to engage in the reconstruction efforts and relief efforts in their own communities, which is a really strong indicator for their resilience. And for example, if a girl were to be identified, let's say there is a needs assessment that is happening, and we identify that in a hamlet there is a girl who doesn't have a father, and she's at risk of dropping out of school, right? And in our needs assessment, we'll say in this family, that girl is a vulnerable child. And let's say as part of the response, there is a relief center, which is a child-friendly space. And you see that this girl is able to go into the camp and she is able to organize all the smaller children. She's able to get them engaged in activities. She's able to get them to eat on time, be engaged as the adults are, dealing with the aftermath of the disaster. This means a potentially vulnerable girl, and definitely she is vulnerable, right? But she also has the strengths and assets that she is able to contribute to other children at a time of emergency. So our needs assessments really need to look at the vulnerabilities in terms of the risk factors, but also really we have to start measuring the protective factors and the existing assets and strengths inherent to everybody, but also really it comes out strongly when a whole community is suffering, people want to help. Here are broadly some problems, and I would encourage you to read it vertically first. There are social problems, there are mental health problems, and then there are problems obtaining services. So then if we read horizontally, all problems can be induced by three things. One is pre-existing, like the vulnerabilities we saw. They are already existing before disaster happened, like poverty. Then there are emergency induced problems. Like when there is an emergency, one of the social problems could be family separation, lack of safety, loss of livelihoods, disrupted social networks. You're not able to access your peer group or your teachers. And there is low trust because there are multiple groups who are competing for resources, let's say in a relief camp. And that leads to more competition, reduced trust, and reduced resources, right? And then there are humanitarian response induced social problems, such as overcrowding, lack of privacy. Sometimes communities don't have information on when food, for example, the relief trucks are going to come to a certain place. And when that information isn't there, there can be a lot of anxiety, which is created by the humanitarian response, which tells us that it's really important that when delivering humanitarian response, to really have your communication in place and also organizing social life so that we are able to deliver it with dignity to everybody. And in terms of mental health problems, of course, there are many pre-existing, as we said, between 20% globally have some sort of a mental health condition, which could be depression or anxiety. There could be harmful use of alcohol and other substances. People might already have had some sort of suicidal ideation. We have evidence that out of every one successful suicide, there are 20 people who have had the ideation or who have attempted. And that is really significant. And before a disaster occurs, this is how people are anyway struggling with their mental health, right? And emergency induced, as Dr. Prakriti also mentioned, there are all kinds of short to long-term stress reactions. And humanitarian response induced will be anxiety about lack of information, right? Where we get food, how do we ensure that my girl will not be abused in a camp, and things like that, which is brought about by. Sorry, can we mute somebody? And the third level is really problems in obtaining mental health services, right? The pre-existing problems as anyway there is limited access to quality and affordable mental health care. Emergency induced will be damages to facilities, homes, of course, staff shortages because they are dealing with their own response to the emergency. There could be disrupted supply chains in terms of very critical medicines. And there will also be surges in demand, which can overwhelm existing infrastructure. So suddenly you'll have to repurpose hospitals meant for mental health also to deliver emergency relief healthcare. And then finally, there are, of course, humanitarian response induced, which is lack of coordination. There is no insufficient training for emergency responders, which means even when you have people who are deployed to deliver, let's say, psychological first aid, the quality of their delivery is not great, which means people continue to feel under-supported. Just a very quick note on suicide prevention in humanitarian settings. There are some statistics here. I'm happy to share this presentation, but the source is largely Interagency Standing Committee guidance on suicide prevention in humanitarian settings. Forgotten to write the year here. It was 2022, if I'm right. I would really strongly recommend everybody to read this guidance note. It is so very critical. It looks at some contextual stressors at the time of emergencies, which can increase the likelihood of suicide, and limited access to family support, appropriate mental health care at the time of emergencies. There is always widespread stigma around mental health. It is very pervasive, and that can really stop people from seeking help. And sometimes there is also the sense of everybody suffering. Who will I go and ask for help, right? Because there's not that many people around. And we definitely have a need for more data and research on suicide risk in these settings, because it's simply not really well understood in humanitarian settings. And even otherwise, suicide prevention is a very complex psychosocial and mental health issue, and increasingly a public health issue. So just a note there for everyone to please go and take a look at that. Very specifically looking at vulnerable groups and nature of vulnerabilities and activities that can foster preparedness among these groups, right? For example, if you look at children, women, older adults, and persons with disability, the nature of vulnerability for children, I'm not going to take you through the whole thing. It is just to say that dependent on the intersectionalities of vulnerability, like age, if somebody is younger, they are going to be dependent on somebody else. They don't have livelihoods, they don't have access to money, they cannot demand higher level of quality of care, etc. So then you're dependent on other people. And in terms of women, there is tremendous lack of mobility, and again dependence on somebody else to get them the help and support that they need. And dependency really runs through this whole vulnerable groups. And really, I think preparedness activities is thinking about leveraging existing platforms that we already have, like school safety programs. There are self-help groups for women, and there are enabling psychosocial services for older adults. Particularly in private care, there is a lot on geriatric care and support. And if we can kind of have a way to bring that into the public sphere to really look at the aging population, just looking ahead, India is going to get there really soon, right? And persons with disability, we already have something called the RBSK, and Ministry of Social Justice and Empowerment does significant work on mainstreaming disability inclusion. So if we can really look at existing platforms and start to embed services for them throughout the year, but also especially at the time of emergencies, that is going to really speak directly to the vulnerabilities that these groups experience, and to really kind of make response more equitable. And how can you really strengthen preparedness? You start to identify and locate. So in a given locality or a given area, where are these vulnerable groups? Who are these vulnerable groups, right? And for that, the Interagency Standing Committee, they have a battery of assessments to use in the field to assess MHPSS needs. They have been field tested and validated, and these are really good tools. So CSOs, CBOs, and also, at a more national level, district level, state level, these assessments can be deployed through CSO, CBOs by the administrations to really get correct data on where are our vulnerable people. Then you assess the needs and concerns of vulnerable groups with their participation. Right? And then going on to sensitize all the stakeholders. Let's say the district magistrate is the one that convenes all of the departments to really respond in a disaster situation. So who are all these departments? How do we sensitize them on the needs of these vulnerable populations? And fostering communication, collaboration between stakeholders, which again at a district level, the district magistrate is really well placed to do. So at various levels, who are these people who can convene everybody else and foster communication between them? And I mean, basically it is to have a multi-sectoral plan of action, and calling out vulnerable groups in disaggregated data. Because if I just say 20% of people, but in that 20%, how many women, how many children, how many older people, how many people with disability? This is something that we need to know so we can also plan for the response. This is a pyramid.
We have reached time, so please, yeah.
Oh, I see. Okay. So I'm just going to, hopefully, I think others will definitely talk about this pyramid, and we will, I can share this presentation, but really the rest of the core principles, I'll just finish it in a second. These, I'll just show you 6. I'm not going to explain them, but really promoting, protecting human rights and equity, ensuring participation across assessment to evaluation of a program, to involve the community in it, to ensure that no harm happens, especially when we are talking about mental health and psychosocial support. It is, we're really looking at building competencies of people and giving them self-care and making sure they are supervised when they are delivering mental health support, no matter how basic. Even if it is psychological first aid, we have to make sure no harm occurs, because aid can cause unintentional harm. And building on available resources and capacities, as we've already spoken, and integrated support systems, as we've again already kind of mentioned, about multi-sectoral ministries and their existing vehicles, existing healthcare workers or teachers or other workforce, and building their capacity on mental health in emergencies. So yeah, that's basically that. Okay. Happy to take questions.
Thank you so much. One question that I get for you is that
I'm sorry, Mr. Raman, I can't hear you very clearly.
Can you hear me now? Is it better?
Could you come a little closer, perhaps, to the laptop?
No, I'm quite closer to the
He's
mic.
actually quite loud. Maybe your volume, you may see your system's volume.
Okay.
Okay.
So the question is, I'll little bit shout for specifically for you. One is that are there any existing mental health interventions that going on looking at the specifically vulnerable populations, and are there any disaster kind of interventions in those disaster prone area it is done? If it is not done, are there any plans for that? That is one question. And second is about how to reduce the humanitarian action induced psychological issues amongst the most vulnerable people. These are the two questions that I've kept for you. Now I am turning to Ms. Dolphy Raman, and I'm sorry we are going little around 15 minutes. We are late now, but despite that, I am trying to provide everyone the kind of time that is needed. So, if you can let me know, Sanchita, uh, can we go little beyond the time schedule of 4:30, or I should?
Sure, 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 sir. Sure.
Yeah, because the four people, five people speaking, it
Hmm.
requires some time for them also. So,
Sure.
right. So let me introduce Ms. Dolphy Raman. Raman or Raman? How is that?
Raman, sir.
Okay.
Raman.
All right. So she is disaster and environmental risk reduction consultant for CRI, Child Rights in Youth, which is one of the important actors in this sector. And she has done her master's in disaster management from TIS. And she has worked also with the National Institute of Disaster Management as a research officer. And she also had, has been with the Haryana Institute of Public Administration and connected with various municipal corporations, state administrative training institutes. In Himachal also, she is connected with the folk organizations and Jagori Rural Charitable Trust, etc. And so she is specialized in research and training in the core areas of disaster management. So she can connect the problems of psychosocial interventions in the disaster settings. So I would like to invite you. So main aspect that you have agreed to talk is about how the caregivers during the disasters are affected and how to care the caregivers. Over to you.
Thank you so much, sir. And just before I begin, I still have 15 minutes with me, right? Or do we have
Yeah.
less?
Uh,
Okay.
please reduce 3 minutes if possible.
Okay, right, right, right. Right. So thank you so much for this opportunity and this topic, first of all, very, very important and very, very less talked about. And so recently I have just submitted work that we had been engaged in since, April. And that is psychosocial care for children in disasters at CRI. And we made sure to include, care of, caregivers and responders and helpers in disaster settings, because more often than not, it gets overlooked. And when we talk about stigma in mental health care, we talk about how those suffering from mental health and especially mental health issues, and especially in disaster settings, beneficiaries or people who have been affected, survivors, you know how they are dealing with mental health issues and how they have gone through trauma, and it is okay to go through that. It's very normal response, right? We talk about stigma. Okay, can we please switch off the mic? I think somebody's mic is on. Right, thank you.
Yeah.
So yes, so as I was saying that it is so normal, and we have tried to destigmatize it, and we have been I would say reasonably successful in that. But when it comes to talking about, issues of fear, anxiety, trauma in responders, in humanitarian aid workers, I would say there is still a lot of stigma, because as, disaster managers, as aid workers, we are supposed to be, we are supposed to have, iron solid resolve. We are supposed to have, good coping abilities and abilities to work in very, very stressful environment. And that in that competition and in that, race to be good at our jobs, to be able to help the communities that we interface with, we sometimes are very, very, cruel to ourselves and, of course, our peers. So, first of all, I would say we need to generate, we learn empathy as a disaster management. The first thing my professors taught was empathy towards others. So, we need to, first of all, also inculcate empathy towards one another, towards our peers, supervisors, juniors, and vice versa. Number one. Number two, also coming to this skill of empathy, of skill of, being sensitive. So sometimes what happens is, if we do not have boundaries in these skills, and because these skills are emotive skills, and we don't have boundaries, and somebody who empathizes a lot with people, which is a good skill. But if we don't have boundaries, we tend to get overwhelmed in these disaster situations, which is again an occupational hazard, right? And our own mental health goes for a toss, and we experience burnout and disenchantment. I have seen so many disaster management people to sort of pivot into other roles wherein they do not have to interface with community so much. So many of my friends, juniors and seniors, have done that, and and this is why. This is because of burnout and sometimes over empathy and these skills without boundaries. They do that. So let us first quickly. I do not have a PPT because I thought the time was very less, and I somehow tend to, follow PPT very religiously. So that would go for the time limit would go, out of window. So let me just very quickly, uh, go over why are responders at a very very high risk of developing psychosocial distress and also PTSD. PTSD is post-traumatic stress disorder, like previous speakers have spoken about. So, because there is direct exposure, you are witnessing death, injury, destruction all around you, right? So, direct exposure. Then there is, of course, indirect exposure. People, when you go to people, the first step is collecting data, doing an assessment, right? Be it responders, be it surveys, anybody, you are going to assess the situation and your community, the communities that you are going to um, I mean, serve are going to tell you stories, you are going to ask them questions, and you are going to internalize trauma vicariously through theirs. So, indirect exposure is also there. Then there is chronic stress. You have to work long hours, there is lack of rest. And usually, in disaster situations, human resources are often below the optimal level. So, we are stretched to our limits, right? And then there are, of course, unsafe conditions, the risk. For example, if you're serving in a conflict situation, you are serving in, active flood situation, of course, there is a danger to your own life as well and your peers. So that risk is also there. And then in responders, we have seen that they also have a guilt and helplessness. Guilt of maybe uh, if they are from the same communities, mostly they have survivor guilt. And if they are from an outside community, helplessness of not being able to help everyone or save everyone. For example, I have myself experienced this very recently in COVID, when we were getting calls left, right, and centers. So, if just to give you an idea, if we would get 100 calls in a day, on a very good day, I would be able to help and a max two people. I'm talking about Delta wave. And two people out of 100 is not a very good number if I look at an outcome. So that feeling of helplessness was something I dealt with. Every morning, I used to wake up with crippling anxiety. The first 5 seconds were okay, but after within, when we wake up, when reality comes to us, and I used to experience crippling anxiety for those 2 months of April and May 2021, in spite of having this training and induction of not getting too involved. But COVID was something that everybody was getting affected, and I experienced that. And then, of course, there is isolation. When you go for response, your traditional or your conventional, your regular support, you are away from regular support networks, and you might feel hesitant in asking for help from your supervisor in fear of being, labeled incompetent or weak. So that is very much there. Again, this entire, sector of humanitarian work and disaster management is very, very taxing on one's mental health if not taken care of, if not, if you don't have boundaries. Again and again, I reiterate that we must have boundaries. I'll come to that in a while. Right. And how does it impact? First of all, whenever we have stress and goes undealt for a while, we start experiencing somatic symptoms. Somatic symptoms is physical symptoms. We will experience fatigue. We will experience that we are unable to carry out our daily tasks. We will, zone out. Our mental faculties will not, support us as well as they would otherwise, and then we are unable to provide effective care. We run a risk of burnout. I have seen people go into substance abuse, then physical health issues, for example, headaches, stomach aches, diarrhea is very, very common in people dealing with anxiety and fear. And then, you know, inability to concentrate. These are some impacts, long-term impacts that, immediate and long-term impacts that people feel. Then there are multiple signs and symptoms that one must recognize in responders. So responders should recognize that in themselves. Their peers should recognize that, and supervisors should also recognize. Supervisors, for managers, for your mentors, whoever is responsible for you in that setting should have a very good lookout for such signs. So, your symptoms are constantly feeling tired, fatigued. You might have trouble sleeping. You might get nightmares. Your eating habits change. Then there is this one very, distinguishing feature that is in the beginning, you might feel, overwhelmed with what you're seeing, and slowly and subsequently, you might develop numbness to that. You might, not be able to feel as you would normally, right? Then a trouble concentrating, sense of
Dolphy,
guilt, like,
timing
yes.
is we are close to the
Right,
time.
right, right. Okay, great, great, great. So these are the symptoms, right? So let me walk you quickly through certain, self-care tips for the responders. Self-care, again, self-care for mental health begins with your physical care. You need to have adequate sleep, adequate nutrition, adequate hydration. Then, you need to have a safe place for venting. For example, peer support groups are very, very important in here because that help you feel part of a group, and that also help you feel less alone. And because sometimes when you're going through this, we feel like it is only happening to us. So peer support groups are very important in establishing that we are not alone, and this is something very, very common. Then maybe journaling can be a good help. Then spiritually, if somebody is spiritual, they can pray. Meditation is very good. So frankly, for me, prayer and meditation never helped. So what I did was I included mindfulness in my daily routine. So there are multiple techniques of mindfulness. If I had more time, we could have discussed. What you can do is you can go on YouTube and just type guided mindfulness for daily guided mindfulness. So you will find different techniques. There are breathing techniques, body scans, multiple techniques that you should include in your daily routine. So whenever you feel stress or you have a panic attack or you are going through anxiety, you can quickly switch to a simple mindfulness technique, takes 1 or 2 minutes hardly, and you can, ground yourself and calm yourself. Then again, setting boundaries, like I was talking about, setting boundaries, it means workload management, having realistic schedules with rest, breaks, and then rotations with your colleagues, then limiting exposures to situations that may be distressing to you. That is more of a guidance to your supervisor as well, because sometimes we're not able to manage our own uh, schedules. So setting boundaries and learning to say no. without guilt is very, very important. And uh, learning to receive no as a response is also important here. Then developing positive coping behaviors, for example, storytelling, narrating, for example, maybe some sort of relaxation or venting activities for responders in the evening or when they have clocked out can be very good, right? Then seeking support when needed is very, very important, right? You have to understand, and this comes with an organizational culture and a societal culture where stigma of going through mental health issues amongst those who are meant to rescue and those who are meant to operate in emergency setting is very, very important,
Can we
right? Right.
can we cut?
So this, I think my time is over. So I think I have almost covered everything that I intended to. Anything that is left, I will try to cover it in the questions
Thank
that
you.
come. So over to
Thank you,
you.
Doctor. Yeah. So one important thing is that most of the caregiver support principles are laid down by the high income countries, wherein they have all institutional arrangements and all systems are in place, wherein they can provide shifts and time management is possible. So they have written all these based on their settings. So how can we change this into our facade situation in a very complex health system we have, and also a mixed health system situation that we have? How can we look at these norms into? I'm not saying norms are not needed. Norms are needed, but norms needs to be that practice oriented norms are also needed. How do you make that is one question. Second is this preparing the caregivers. Uh, at least if you have a registry of caregivers, that will be the good beginning, and then preparing the caregiving. So what is the roadmap towards that? That is the second question that I have. Now I would invite Dr. Ganishta Suri, and she is with the National Institute of National Disaster Management Authority. She's a senior consultant over there, and her specific area of work is strengthening mental health and psychological support within the disaster preparedness, response, and recovery, while fostering collaboration with ministries, authorities, and international partners. So it's a very important topic that she is going to discuss with us, which is the crisis. To understand the crisis during an emergency situation, and particularly in the context of the first time responders and first time volunteers who don't know the larger challenges related to mental health. How should they approach a kind of volunteers and first level respondents? How to respond during a disaster situation? Over to you, Dr. Dhanishta.
Good afternoon, everyone. So, let me extend my heartfelt appreciation to Sphere India for bringing together such a diverse group of stakeholders on one platform. And NDMA truly appreciates such initiatives because they allow us to share, to learn, and collectively strengthen our national and international approach to disaster management. And also, it is so very important to speak on such subject because it is very crucial and urgent understanding the mental health crisis and emergency, because this is not just a technical issue, it is humanitarian imperative. So disasters do not just destroy buildings, they disrupt lives, families, and the very sense of safety people carry within themselves. So the scars of a cyclone, a flood, a landslide, a major accident are not only visible in debris and statistics, but they are also carried silently in sleepless nights, in a child's fear, in the grief of parents, and in the invisible burden borne by the communities. And in such moment of despair, first responders and volunteers become the face of hope. So what you say, how you act, and even how you simply sit with someone in distress can make the whole difference between the despair and recovery. So as the National Disaster Management Authority of India, we firmly believe that psychosocial support is not an optional extra. It is as essential as food, as shelter, as medicine. And I'm proud to say that the government of India continues to encourage and invest in initiatives that strengthen mental health and psychosocial support in disaster management. But what do we mean by psychosocial care in disaster management? So, at its core, the aim is to protect, to promote, and to restore the psychosocial well being. So, two P's and one R. I'll repeat again, to protect, to promote, and to restore the psychosocial well being so that survival can move from crisis to recovery with dignity. The guiding principles are pretty simple but profound. So, number one is safety first. So, calm comes before counseling. Number two is respect and dignity. So, every survivor deserves compassion and not pity. Number three, but very crucial, is doing no harm. So, sometimes silence is more healing than rushed advice. Plus, we strongly believe on not re-traumatizing the survivors and victims by asking the same questions again and again, that how they are feeling and etc. And also the community participation, because healing becomes stronger when it emerges from within the community. So we always support the local leaders and volunteer groups and always encourage them to come forward and participate. And last but not the least, the cultural sensitivity. So local traditions, local practices, and local stories often carry therapeutic values. And I always remind my all teammates that if food and water is what keeps the body alive, so psychosocial care is something that keeps the spirit alive. So in emergencies, psychosocial care cut across all groups. So children lose their sense of security. Women may face high-end risks. The elderly feel abandoned. Persons with disabilities, they struggle with access, and responders themselves often suppress their own traumas that they get being exposed to, post disaster scenes, which is really very heavy. So the needs range from the very basic, that is reassurance and psychosocial first aid, to highly specialized interventions for those at risk of long term conditions. And we really need to remember that disaster not just only cause trauma, they also disrupt the natural support system, the families, the schools, the workplace, the community networks. And of course, when these break down, recovery becomes very hard. And I'm so very sorry for the background, because I'm really hopping from one meeting to the other. And I'm really commuting, and I have stopped my vehicle. I came here and I'm taking this talk. So now coming back to the topic, the question comes is why psychosocial care is important. So it is because it should be treated as the essential humanitarian assistance, and not just an afterthought, but as a core part of the relief operation. Because a safe camp without psychosocial support is only a shelter, but a safe camp with support becomes a community of healing. So now please allow me to share a few evidences from the recent disasters where psychosocial interventions really made a tangible difference. So number one, I would like to speak about Project Rehabar, that was initiated by NDMA for the Sikkim survivors and victims, that happened in the year 2023. And I'm talking about the GLOF, that is Glacier Lake Outburst Flood. So NDMA initiated this project for the affected communities, where trained volunteers provided immediate psychosocial care alongside relief. So survivors readily reported lowered level of de-stress, and communities felt more connected. And this is what we were aiming for, right? But the key lesson that we learned was early outreach prevents long-term trauma. Second incident that I would like to speak about is the Balasore train accident that happened in Orissa in the same year, in the year 2023. And it was one of the India's, worst railway tragedies we have seen. And we really saw that beyond the medical triage, and survivors and the families urgently needed psychosocial first aid at the stations, at the hospitals, and even in the waiting halls. So volunteers stepped in to calm the panic, to connect the families, and reduce the chaos. But what was the lesson that was learned is Even in man-made disasters, psychosocial care is a vital pillar of response. Now, I would also like to speak about the Wayanad landslide that happened in Kerala in the in the year 2024. So we really deployed our multiple teams, psychosocial teams in the camps, and we realized that it really reduced the anxiety. It also built trust and prevented the spread of rumors, which is very important, and we really focused on that. And when we talk about mental health and psychosocial support, we have to talk about COVID-19 pandemic. So here, community listening posts, telecounseling, and peer support networks became major lifelines. So they taught us that mental health support must extend beyond the hospital, and it has to reach the homes and communities. So what this example really teach us that the psychosocial care is not an abstract idea. It is very practical, very measurable, and life-saving. So, what the first responders and volunteers do on ground is the question. Number one is listen first and act next. Your silence and presence can sometimes heal more than words. And number second is practical help is emotional help. So, reuniting a child with a parent may relieve more distress than a counseling session. So, reading the whole situation and catering to the demand is what is needed. So, number third is identifying the red flags. So, withdrawal symptom, hopelessness, suicidal thoughts, survivors and victims talking about losing their appetite and having these recurrent dreams. These must be referred quickly for the professional care. And most importantly, is caring for yourself, because responder fatigue and burnout are very real and very less spoken about. So, peer support, rest, and self care are not just luxuries, but they are the necessities. I really often repeat that the first medicine in disaster response is not a pill, it is a human presence, empathy, and a listening ear. So in disaster, we are not just responders, but we are the bearers of, dignity and carriers of hope and custodians of resilience. And, I'm talking on the behalf of all of us, because each one of us really count. And creating hope through action is the theme and focus of the World Suicidal Prevention Day, that is today, that is celebrated today, 10th September 2025. So one thing that I would like to, conclude my talk by saying is mental health support is not just charity, it is survival. So every word of kindness, every moment of attentive listening, and every act of dignity that is offered really saves life. And it is as important as providing medicine or providing food. So this ensures that in every disaster, survivors rebuild not only their homes, but also their courage and their confidence. Because this really makes them easy to cope, which is easier said than done, but this is what we really focus on. And let me end with a thought that has really guided me through, my years of experience in this field. That is, disaster really tests our structures, but they also reveal our true strength. So if we respond with empathy, we do not just save life, we also restore humanity. So this is what I really had to say in these quick 5-10 minutes that I am able to squeeze between the meetings. And I hope this really, help to
Thank you.
guide you people out and create an impact, which is something that I was really focusing on today. Thank you
Thank
very
you
much
so
for
much.
having me today.
So there is one question from Mr. Navdeep Singh Atta already. Apta Mitra, he is introducing himself as in his name itself. किसी भी डिजास्टर के टाइम जो फर्स्ट रिस्पॉन्डर के नाते कार्य करते हैं वो वॉलंटियर, उनकी कहीं पर कोई कदर नहीं होती, ना उन्हें कोई मानदेय दिया जाता। जो लोग पैसों के लिए काम करते हैं, जब किसी प्रकार का कोई डिजास्टर होता है तो वो लोग नजर भी नहीं आते। दिल्ली के अंदर जो लोग आपदा मित्र हैं वह ग्राउंड लेवल पर काम कर रहे हैं, उनकी कहीं पर कोई भी कदर नहीं है वॉलंटियरों की। दिस इज समथिंग दैट ही हैज मेड अ कंसर्न. Now, you can think about how this particular issue of, and this is a burning issue also, because whether it is various types of accidents or emergencies or whatever is happening. So this is important that how this first responders. I have also during mid 90s the Orissa super cyclone when it happened. I was there in the place, and I was one of the first persons to move out of those safe places and organize people and all that, and have seen this from then to now. So this is something that we need to look at. Everyone, every panelist, I would request you to switch on your camera and let us get into this discussion mode. And I will request if there are any questions from the audience, it is time that you can put them into the chat box. Uh, So first question, I had asked you, Mr. Ratnu, about the mental health policy and also the large scale capacity building challenges that in terms of institutional arrangements that the NDMA and NIDM and similar organizations are facing.
Uh, Thank you. Actually, when we talk about large scale capacity building, particularly in psychosocial support care, or for that matter, any part of the entire disaster management cycle, it's a something that we all, including NDMA, has to learn that disaster management is not responsibility of NDMA and NIDM alone. There are large number of people, stakeholders inside government and outside, who need to be roped in, and that is what Sendai framework talks about. Mainstreaming DRR. Uh, Ganishta Shuri, if she's still around, then I like to emphasize that though very well appreciating coming out from the DRR family, the work being done by NDMA in bringing out a lot of guidelines. But one thing where I have a strong, divergence of view from NDMA and this thing is, taking upon yourself that NDMA has done this thing. NDMA is an authority. Let authority not become an executive body. Let authority assess. A judge should not become a lawyer. uh, you are basically need to ensure that the people who are responsible for doing and delivering those things, whether they are delivering their job or not. And mental health, as rightly said by one of the speakers, that there are pre-existing conditions of vulnerability. When people, Jyoti Ravichandran, I think, emphasized on that. So we need to understand that we require in this country uh, mental health care support at the grassroots level. Unless this government in the health and family welfare department with patronage of the government of India, this massive roadmap of the mental health care in normal times is not in place, we will never be able to address this issue in the crisis. Because if we are not able to handle the normal situation, large number of people, Jyoti told the figure of 22%, very severe cases of mental health during these disasters. I think more than 10% are already there in the normal situations also. And large number of them go unattended. And I'm not talking about short-term phases of anxiety and depression, which all of us go through in some or other forms of times. But I'm talking about the serious cases of psychotic problem which require and there is no care. We will have to think like the barefoot doctors scheme of China. We will have to think about a massive army of mental health people at grassroots level. In a village, I always say that a woman will identify who is a trustworthy saheli in the village, who can be trusted upon, who does not do rumor mongering, who keeps the privacy of the people. And those both men and women can be identified easily by developing appropriate tools uh, through participatory approaches to identify who can be best 2 to 5 people, both in men and women in that particular village, panchayat or revenue village, who can be trained on basic skills of identifying the problems and referring them to the nearest healthcare facility. And we'll have to have at least up to PHC level that we have the mental health givers. So that is where the NDMA can play a huge role, Ms. Suri. that where you can push. I was writing to each of the ministry from NITM that you need to mainstream DRR. What are the thematic area emerging out of each of the ministry, and we have to ask them to deliver them. If NDMA or NIDM for that matter, we can be catalyst to just that and do building capacity of the master trainers at the national level. But again, we will have to, again, second challenge is siloed approach. Third challenge is the demand factor from the states when they give, when we have a, you know annual training calendar is drawn out, no state talks about the psychosocial care. They will only talk about the damage assessment. In the damage are though we many times talk at the academic level that damage and losses are not only to the material assets, the to infrastructure, housing, but they are also equally to to people's life and livelihoods, and they need to focus on recovery of that. But seldom that is actually translated into action by the states, because they want to make more visible impact. And I do not want to go to more details about how most of the states are crippling with the corruption at cutting edge level. And how people want to only engineer driven projects where they can make money at the lower level, the contractor and the lower level bureaucracy, and public representative, everyone at the lower level. So we have to cut across these challenges. We have to address silos. We need to address this issue of you know having a national level policy on mental health, where not only a blue a white paper is brought out, but there is also a tangible material resources are allocated for human resources at that level. And of course, we will have to have more focus on normal time into building a multi-layered cascading pyramid of training of trainers, master trainers, who are readily available at the state level to quickly get into action.
Thanks. Thanks, Mr. Ratnu. If there are some questions, I'll come back. Now I'm not seeing Prakriti here, so I'm coming to Jyoti. So this is about is there any existing mental health intervention that is focusing on the vulnerable capacity communities, and what are the
Yes.
key experiences that we are getting from them?
Sure. So, across, so for example, for UNICEF, mental health and psychosocial support is a multi-sectoral mandate, which means we program with health sector, education sector, and women and child, so child protection. So really looking at vulnerable children who may have gone through neglect, abuse, trafficking, labor, etc., and looking at children in schools and looking at children in communities and healthcare facilities. So if you look at that, there are at least 11 schemes. I'm sure there are actually more that are community-based programs. So the National Mental Health Policy of 2014, which is basically an updation of an 1882 policy, that was really talking about rights-based, community-based mental health support. Which means away from facilities, but really it's the didis that Dr. Rajendra was really talking about. It's the Anganwadi worker, the ASHA workers. So the National Health Mission of the Ministry of Health and Family Welfare has what is called the Rashtriya Kishore Swasthya Karyakram, or RKSK, which has multiple peer educators who are trained on multiple health needs of adolescents, of which mental health is one. So that is one large scale flagship that we have access to at the village level, where you can really integrate mental health training into it. Then there is a school health and wellness program, which is a convergent program between the Ministries of Health and Education. That also has like some 11 pillars, of which 3 are mental health related modules. Again, the support is really to give them technical support into how do you update the mental health module so that it's really easy to transact and children are able to directly relate to it in a classroom setting. So how do you make mental health extremely accessible and relevant and culturally sensitive where the children are? So these are 2, and then there are across ministries, there are helplines. So of course, Telemanus, which is a nationwide multilingual 24-hour helpline for mental health, and Women and Child Development Ministry of Social
Just
Justice and
one
Empowerment.
question here. during disasters, are they helping people, these helplines, or these are?
Absolutely. So, particularly in disasters, so that's why we have to really leverage that, right? And also specifically for children and adolescents, because they suffer in very different ways. As one of the vulnerable groups, the kind of dependencies that they have on adults and also systems around them, and the ease with which they can access things that an adult can, it's simply not there. So then how can we really sensitize? How do you help children, adolescents, and also their caregivers when you're speaking about the challenges that children have? Because the level of acceptance that adults around them have about a child's mental health needs really dictates the quality that they will get through their lives.
Thank you. I'll now go to Ms. Dolphy. This is essentially about the uh, the question that I had placed to you was the one second. Preparing caregivers. What are the key principles and practices? What are the boundaries?
Right. So if I remember correctly, you had also asked me to
Ask
contextualize
the ground
needs.
situation specifically, because
Right.
the Western setting to the ground that we are in.
Right, right. So, so in my talk, whatever requisites for self-care and care of responders, all of those were based on guidelines from NDMA and NIMHANS. You would see that I focused more of my talk on how individuals and groups of humanitarian aid workers or responders, what is it that they would require? Because that requirement remains more or less universal throughout the world. Of course, some in some situations, some would vary with cultural differences, but more or less they remain universal. How many hours can the human body continuously work? How much stress can their mind take? Right. So more or less they will remain universal. Right. Number one. Number two, uh, in India, the problem, when we look, try to look at a problem and try to define it with lack of availability of certain maybe mental health care workers, and then try to define our boundaries. I think that is a very convoluted way of doing it. In India, we don't have, there is no dearth of availability. We are number one in population. We have a good demographic dividend. We have 27% of population is youth. So there is availability. The issue is how to channelize them into this particular area, and
What you are
how
saying
to
is it is about resource allocation
yes, yes.
rather than
It is
resource availability.
exactly, exactly. It is about training them. It is about channelizing them into this area. Then a lot of it, more than I would say 70% of it, again depends on funding allocation. Where are we allocating the funds? Are we allocating it into training our communities, training our existing systems? Right. So this is policy level, of course, but while that is happening, right, what we can do is in when I was in NIDM during COVID, we understood that in any training we need to include a session on mental health care and sensitize people towards that. So this tradition we kept this going even when COVID got over, the emergency got lifted off, and we kept this in our face-to-face trainings also. I was in the child-centric DRR unit. So sometimes in our 5-day trainings, we would have one full day dedicated to mental health care, so that at least those people, while we don't have the numbers right now, right, we at least those people who come in touch with us go out and are at least sensitive towards those needs. So just I will just quickly say two things so that maybe through this platform someone hears it. In our DM Act, we need to codify care of helpers, care of responders. Right now, DM Act does not majorly talk about it, explicitly talk about it. We need to codify that. Why we need to codify is because organizations, when they come to bring responders or send responders on the ground, there is no compliance right now. There is no minimum requirement of giving
Right.
mental health care to their workers, their responders. So once there is codification of that in DM Act, we can ensure compliance so that anyone who enters that disaster area with volunteers, there are young volunteers, we can ensure that they receive the requisite
Can
mental
we?
health care and right. So that was
Thank,
from my side. I hope that helps.
thank you, Ms. Suri. This is about the reflections. We have the couple of volunteers and frontline workers. They have responded. How would these realities are there and the efforts are also there, the efforts to recognize, the effort to do the deploy, train, and also recognize, respect, all that is there, but there is a mismatch when it comes to the actual implementation. How can we look at these issues, is the question.
So I would come to your question as well, but thanks to Ratno sir, he has mentioned about integrating MHPSS plans into the existing DRR. So I would like to focus on that also. So NDMA
All
is
right.
initiating the implementation of a national level mental health and psychosocial support program commencing with 12 states. And the project really focuses on the comprehensive resource mapping and the establishment of a trained deployable pool of MHPSS professionals, particularly counselors who can be rapidly mobilized in the event of a disaster. So, concurrently, we are supporting state level authorities in integrating dedicated MHPSS plans into their existing DRR frameworks to ensure a systemic and sustainable approach to mental health in emergencies. And in parallel, we are also developing a community based intervention model aimed at strengthening MHPSS capacities at the panchayat level. So this initiative emphasizes ecosystem-based green approach to community mental health, promoting the creation of safe and inclusive spaces and fostering psychosocial resilience and mobilizing local leadership. So the program actively engages community leaders, the grassroots workers, and the local NGOs to build a decentralized community-led response system rooted in the local context and resources. And yes, I was going to through the chat section, and I do realize we have our Abda Mitras and Abda Sakhis who have, really voiced their concern. But I would like to assure that on the upcoming Foundation and Formation Day of NDMA, they are celebrated. They are the whole reason that we celebrate Abda Mitras and Abda Sakhis. We invite them, we encourage them, we motivate them, we celebrate them. Yes, the gap is always there, but we are continuously working on bridging the gap, that you just spoke about.
Right. Thank you. So there is one question probably Jyoti has answered partially, but maybe Mr. Ratnu, you can also look at it. This is about the NRH, the National Health Mission, the mental health issue. How are they addressed? The other question that has come is about how to have an IEC BCC kind of program for the for addressing the risk-taking behavior. These two questions are there. If any one of you want to pick up, otherwise, I think we are good to uh, close them.
Uh, in the National Health Mission, also, I think there's a component of mental health, and this part is there. But as Dolphy rightly said, that there's no dearth of human resources. What we require is a deployment plan. We need to see that those people who can be drawn, but we need to identify. We need to have a policy framework for identification, adequate remuneration, and it's not in name of volunteerism we give them motivation and everything, but people require bread and butter to live, they need their livelihood. Otherwise there'll be attrition rate will be so high that people whom you are asking if they are educated, I feel that you do not require a huge kind of education. They can be 10th or 12th pass people who can be oriented. What is required is a right kind of aptitude and right kind of attitude these people are having. We have to have a tools to identify these naturally gifted counselors at the grassroots level, and that has to be done in coordination with the line ministries. It has to be done by Ministry of Women and Child Development, by the Panchayati Raj, Rural Development Panchayati Raj Institution, by Health and Family Welfare Department, and they have to be there in the normal times, and they have to be oriented what additional cascading needs are there for the crisis time, which you have to orient them. So that is the challenge that we will have to address.
Thank you. I think it is we have discussed in length all the various aspects that are required around the mental health aspects of uh, disaster and emergency management. And it was very important, very critical points came about what could be done. And also we have laid out what are the key challenges that the sector is facing and how we can address them. So I hope, this discussion was solution oriented, and on we are in a very incremental manner, as Dolphy was and also Ratnu was pointing out. We are moving in an incremental manner. That is true, but on the other hand, our goal and our overall requirements are very, very vast in terms of its scale and also its dimensions. We have to go much more than, we have to do much more than what we are doing currently. And we have to be, for that, we need, as everyone has pointed out, multi-departmental, multi-sectoral, and the state, civil society, private sector, community, all that has need to come together with capacity building, with IEC and BCC wherever required, with sufficient deployment of human resources and also the other resources that is needed. And the authorities, as has been suggested, to oversee these issues, particularly the mental health issue. If the authority can oversee the things and ensure that each of the components are going well and the hands are working properly and resources are made available, probably in days to come. Currently, we are at the very beginning of addressing these issues. We are realizing the problems at least, and we are starting to move forward with some kind of realization that we need to do certain things. So, with that sense, we can close this discussion today, and I thank every speaker for the day and the people who put up important questions, suggestions, and thoughts. Over to you now. Back. Sorry. Sanchita, over to you now.
Yes, sir. Yes. So, good evening, everyone. On the behalf of Sphere India Academy, I, Sanchita Biswas, would like to extend our heartfelt gratitude to all of you joining us today for such an enlightening webinar. Your participation and engagement have made this session truly insightful. In a context where disasters and emergencies increasingly affect both physical and mental well being, your dedication to learning, sharing knowledge, and promoting psychosocial support is invaluable. A special thanks to our distinguished keynote speaker, Sri Rajendra Ratna sir, former IAS and Principal Secretary Tamil Nadu, for his inspiring address on national policies framework for psychosocial care. We are equally grateful to our speakers, Dr. Prakriti Kashyap, Ms. Jyoti Ravinder Chandan, Ms. Dolphy Raman, and Dr. Ghanishta Suri for their thought provoking sessions on stress, trauma, caregiving, and mental health interventions during emergencies. Your expertise has provided participants with practical insights and actionable strategies. We would also like to extend my appreciation to Mr. V.R. Raman sir for excellent moderation. Your guidance ensures smooth discussions and meaningful engagement throughout the entire session. To all our participants, first responder, volunteers, humanitarian practitioners, mental health professionals, and community stakeholders, thank you for joining us today and taking your time out to be part of such a crucial conversation. Your presence and contribution reinforce the importance of integrating psychosocial care into emergency preparedness and response. We look forward for your continued engagement in upcoming sessions under Sphere India Academy, where we will continue to explore such themes in mental health, disaster risk management, and humanitarian response. Please stay connected through our platforms and share your feedback to help us improve our future session. Stay safe, stay resilient. Thank you once again for joining us today.
Thank you.
Thank you. Thanks, everyone.
Everyone.
Thank
you.
you.
Thank you. Thank you, speakers. Good sharing, good sessions.